Welcome to the 2020 Virtual Community Forum. This is the Complex Care of Family Journey panel tonight. I am so thrilled to welcome the Shrader family, Dr. Charmaine Wright and Lynne Fogel, who will be our moderator this evening. I'll tell you about the presenters this evening. Wade and Carol Shrader are the parents to Benjamin, Mason, Claire, and Cate. In 1997, Benjamin, Mason, and Claire were born 3 months early, changing the direction of their lives. Could the birth of triplets do anything less? Benjamin and Mason were diagnosed with cerebral palsy in 1998. It was this diagnosis that would lead Wade to specialize in pediatric orthopedic surgery. Today, he runs the DuPont Hospital for Children's Center for Cerebral Palsy. In 2008, an 11-year-old Mason created a blog, The Blessing Counter, and encouraged Carol to share their story. His willingness to have his story told so that even just one family could find hope inspires her still. The triplets graduated from college in 2019. Benjamin is currently working on a local Senate campaign and is an advocate for voting rights for the disabled. Mason is in his second year of graduate school at Texas Tech University. He is getting his master's in classical archaeology, and his main research is in disability in the ancient world. Claire and a triplet without CP began occupational therapy school at Thomas Jefferson University in August. And Cate, born when the triplets were 8, just started high school. It is the Shrader's family's goal to remove helplessness and hopelessness from the diagnosis of cerebral palsy. Welcome, Shrader family. We're thrilled that y'all are here presenting tonight. I'd like to welcome Dr. Charmaine Wright. Leading multidisciplinary teams has been a highlight of Dr. Charmaine Wright's career. A dual-trained internal medicine and pediatric primary care physician, she attended Harvard for college, medical school, and residency. Following residency, she completed a Robert Wood Johnson Clinical Fellowship at the University of Pennsylvania and joined the faculty. As a Med-peds primary care physician caring for complex patients, medical educator mentoring residents, and a health services and clinical researcher dedicated to improving health disparities, she is passionate about implementing teams and programs that work for our most vulnerable patients. She works to bridge the gap between pediatric and adult care for patients with childhood-acquired medical conditions. She joined Christiana Care Health System as the Director of Center for Special Healthcare Needs. She serves on the board of the Easter Seals Delaware and Maryland Eastern Shore. Over the past year, the Center for Special Health Care Needs has grown beyond its signature primary care, Down syndrome, hemophilia, and cystic fibrosis programs to also include sickle cell, cerebral palsy, women's health, developmental psychiatry, gastroenterology, urology, and the Mary Campbell Center programs. Wow, amazing. She is a member of Christiana Care's employee resource group Diverse Abilities, working hard as of late to end discrimination of all kinds and improve the health of people with disabilities. She lives in Delaware with her husband Sean, kids Lydia, Luke, and Logan, and a dog Sunny Montego. Their families are from Jamaica, and they think outside of Delaware, the beaches are the best. She enjoys reading, riding bikes, and eating. And we have Lynne Fogel, our wonderful moderator this evening and community council member. Lynne lives near Columbus, Ohio, and is a mom to 2 lovely girls, Natalie, age 15, and Erica, age 18. Erica is a senior in high school and has spastic quadriplegic cerebral palsy with dystonia and cortical visual impairment. Lynne came to the community council via Pedal with Pete, with whom she has partnered in the past to provide adaptive bikes to kids with CP in Central Ohio. She has run a parent support group, CP Parent Columbus, an official chapter of Reaching for the Stars since 2004, and volunteers as a parent mentor in the Connecting Families program at Nationwide Children's Hospital. Lynne has served on the Parent Advisory Council of Children with Medical Handicaps program of the Ohio Department of Health since 2014. She has worked part-time as the Central Ohio Family Support Specialist for Ohio Family to Family Health Information Center since 2016. Welcome, Lynne. Thank you so much for moderating this evening. I'm going to turn my camera off and turn myself on mute until you tell me to read the questions in the chat box. Thank you. I'm so looking forward to this presentation.
Thanks, Jen. Okay, that's quite an intro. We have some great folks to chat about complex care tonight, and we have a lot of great topics and a lot of great questions on tap here. So we've sort of put the topic of complex care out there and some suggested topics that might be covered. And we got some questions back in advance from members of our community council. And so we'll be covering those tonight. Hopefully we'll have time to get to them all. I will say, for anyone who is watching this recording from a link off the AACPDM website or being distributed through CP channels, that we're probably in for a pretty long conversation because we have a lot of great questions here to tackle. So please feel free to pause us, at any point and come back to the conversation as you have time. One of the great things about doing this community forum virtually this year is that we are pre-recording all of these great sessions, and that families all over the country, and not just in the area where the meeting is taking place, will have a chance to hear these great speakers and the conversations that we're about to have. So we're going to kick it off with our complex care topic by inviting our physicians online tonight to give us a little bit of a definition about what is complex care and how is it that so many CP families find themselves in a position of needing a complex care team.
All right, I'll go first, Charmaine, I guess, and I'll take it from both the parent and the physician's perspective. I think as parents, we know that navigating healthcare is hard. And, we often have different subspecialists that we're seeing, even if we're just seeing just the orthopedist and the physical therapist, the occupational therapist. Sometimes that communication, I think, is hard. And so the field of complex care or medically complex pediatrics, I think has really risen out of a recognition that our healthcare teams need to do better in coordinating care and communicating that. And so, it's been exciting for me through my career to see us get better at that. I think we still have a long way to go. So, complex care can be defined very differently from region to region, from center to center, from state to state, but there are starting to get some commonalities about definitions about what that looks like, about who is the primary pediatrician that usually takes care of children with complex care. Charmaine will talk a little bit about that she wears both the pediatric and the adult hat, and talk about transition for that. For me as the surgeon, complex care often tries to identify all the different needs that child may need in preparation for a surgical encounter. And I think our outcomes are better when we all are on the same page with that. It often includes a complex care pediatrician or a medically complex pediatrician, and how their role is in terms of the center of that team, or used more of as a referral source. Kind of depends a little bit on the resource. I know there's some hospitals where the CP center is really centralized in the complex pediatric clinic with more of a medical home model. And I think that's a great thing to kind of to shoot for. At DuPont, we're kind of known as we're a surgical tertiary care referral center. So we end up kind of focusing a little bit of that in my clinic, in the orthopedic group and in the CP team, but we work really closely with our complex care pediatricians, especially during times of planning for surgery. So hopefully that's a little bit of a introduction to the topic.
And I will say, Dr. Shrader, you teed me up completely by using the term medical home, because that is always, if you take nothing from this, it's that folks with cerebral palsy need a team. And the medical home concept was one that started about 10 years ago in the primary care world, where The primary care team was going to just absorb folks with complex conditions. You would have a care coordinator there, you'd have nursing there. And guess what? Sometimes we left specialists out. And so now we're trying to rework medical homes where specialists are there and present. And at Christiana Care, that's what we're trying to do, utilizing all the local resources we have from DuPont, for example, but trying to build a place where it's one-stop shopping. Because complex care requires lots of individuals and lots of vectors of communication. So the more simple we can have the geography of it, the better.
Okay, that sounds good. And with that introduction, I think I'll tee up a couple of questions that fall under our care coordination topic. One of them was, let's see. I had them numbered. Are there complex care specialists? What are they called? And I think that Dr. Shrader mentioned a couple of different specialists who fall into the arena. But then how does the team support the family in making decisions? And I know that's really a central concept to the medical home idea. And something that also ties into that was, are there tricks to scheduling that might help lessen the number of appointments and make it easier on families? And I think that's a key component to what the care coordination team does. So let's just sort of lump those together and maybe talk about how that can be really helpful to families.
Sure. So, we mentioned that a lot of times the medically complex pediatrician is now kind of a new evolving field, really, if you will. We have, as part of AACPDM, as part of this academy, we have a special interest group on complex care. And that has kind of risen out of really a group of different physicians, but primarily led by the pediatricians, who are the internal medicine specialists of the kids, and trying to bring together other subspecialties of nursing, of social work, of orthopedics, of neurosurgery, to try to really focus on how the mechanics of that work in terms of care pathways to try to improve outcomes and try to take care of complex medical issues across specialties, as Charmaine mentioned. At our institution, we have two kind of sets of pediatricians that do that. We have complex pediatricians that are the primary care doctors for some patients that live locally and that are able to see them regularly. And these are pediatricians that like to specialize in some of the kids that are complex care. They may have some kids that are typically developed without CP and other things, other disabilities, but they tend to focus on that. And then we also have a hospitalist group that also really focuses in specifically on the hospital management, the perioperative management of these kids, getting them ready before surgery and then ready after surgery. A lot of our kids with CP, even if they're not, even if they don't see, they're not trached, or they don't have a lot of other devices, or they often will have some medical issues going on. And so I firmly believe that communication and optimization is important to get them ready. As I think it's good and great to be communicating in normal everyday life, but it's really important when we're starting to talk about considering a surgery for them. And so we have a very formalized checklist process of making sure that the kids see everybody that they need. But it's a bit of a burden sometimes on families about trying to come back. And so we really work hard to try to emphasize the importance for that. We have a patient navigation system that tries to coordinate times with visits so that we're not forcing families to come back and forth unnecessarily. So I think that concept is really important. In Dr. Wright's case, they have all those folks kind of centered in the same clinic, and really that makes things a lot more convenient on the transition clinic side.
And I'll just add that on the adult care side, folks aging with CP, we are starting to know a lot about what that looks like. And families always ask me about aging with CP and that specialty. And so we've learned a lot nationally from University of Michigan, for example, that the job of a primary care doctor for someone aging with CP is we must look at cardiovascular care and pulmonary care differently than you might someone without CP. So we actually built our program honestly to match what's provided at DuPont. As we looked at what families were used to getting and tried to map as best we could, tried to coordinate as best we could, so that that transition would be easy. But it is a model that works when you have things in one place and when you try to have a nurse navigator easing the pathway of all the different specialties who have to be involved.
And I would say too, I can say from our experience in Columbus at Nationwide Children's, we have a comprehensive CP clinic that we're a part of, and they do a good job of coordinating those things. But I will say, if there's a family listening to this that feels like wherever their child is receiving care doesn't have that coordinated team, I would say don't hesitate to reach out to whoever you feel your child's primary care provider is, and don't hesitate to reach out to that team, to a social worker or a nurse or a clinic manager for that physician, and ask for help with coordinating that. With Ohio Family to Family, we had a conference a couple of years ago, and the conference was focused around the medical home model and collaboration between parents and professionals. And there was a parent whose child does not have CP, but she attended that conference. Her child has a different diagnosis, who nonetheless, at Nationwide Children's Hospital, he saw a number of different providers in different areas. And she said after that conference that she felt empowered to contact the nurse at the clinic that her son goes to the most and say, you know, we're just really running ragged coming to all these appointments. And is there any way that you can help us coordinate this so that we don't have to make as many visits? And she said, well, of course, let me help you do that. And she took it upon herself to sit down with this mom and talk to her about all of the different people that her son was seeing, and to reach out to the other departments and to coordinate with them. So a little bit of advocacy on the part of the parent, and just reaching out. Like, it never occurred to her that that would be something that she could ask for. She felt like it was something she had to coordinate as a parent, but as soon as she reached out and asked for help with that, there were professionals who were eager to make that easier for her, and she said it made such a difference in their life.
I think that's a great point, Lynn. I mean, so, you know, this process is evolving. 20 years ago, complex care really wasn't a thing, and care coordination really wasn't happening. So in our careers, we've seen that. And Nationwide does a great job of that, right? And they've been leaders of setting the pace on ways to do that better. But I agree with you. I encourage you to go to your local providers and ask for those things, and kind of help direct them to examples of better models. And I think, you know, make those statements to the healthcare systems, because eventually, you know, these things, the better care we provide becomes more cost-effective care for the systems and for the payers. And you know, I know at the Delaware Medicaid level, there's a big interest in starting to do a lot of complex care management to decrease emergency room visits, for instance, right? Which is a huge deal. And so I see that, and it's encouraging to see it growing around the country. So I absolutely agree with you. Encourage our parents to go ask for those services.
There are a number of care pathways also on the AACPDM website that I use, and that every primary care doctor can go use, that are a great support, just also to navigate and to sort of see what the guidelines are. So I find those really helpful.
Okay, and then another corollary question to that was, one parent wanted to know, how can families best manage communication between physicians and non-medical members of their team, like therapists and school personnel? That's a huge issue for sure, and something that parents definitely feel like falls on them, and that they maybe don't really have the time or the energy to pursue. But again, I would say more and more when I go to medical conferences, I'm hearing the team members on these clinic staff talking about how to help families with this. And so again, I would say, reach out to the social worker in your clinic and say, you know, any tips for how I can communicate this information to my child's school team, or if they're in private therapy, or, you know, anyone else who is a part of this child's life and their overall well-being. And I think that that would be, you know, they would be eager to help with that as well.
Mhm.
Yeah,
I'll
I
say the
totally
only
agree with
COVID
that.
lining has been events like this. And on Friday, I was meeting with a mom, my patient who was in a group home, their behaviorist. We had the OT on the phone who was helping with some sensory issues, but the phone means it was like a Zoom meeting like this. And so, you know, it was great for everyone just to touch base and actually see what we were talking about. And there was one plan that came out of it. So I will say some synergy using virtual platforms has been really useful.
And ask you know, again, tell our families, ask for, is it okay to reach out to, say, your orthopedic surgeon, say, is it okay for the therapist to contact you? And I do a lot of email dialogue back and forth where we're able to kind of fine tune care plans with our orthotic specialists and do that, because it's hard to try to coordinate some of that in the clinic and try to see what they're seeing out in the community when they're trying to help the kids in something that I might not see in the clinic. And so I would encourage those docs, those physicians, those caretakers to be open to that, to be able to take the time to interact with that. And then you mentioned social workers. I think social workers are key. They're a key piece of this care coordination and complex care. When we book a surgery that we know is going to be 3, 4, 6 months out, we will have our social workers see that patient, you know, in the next 3 to 4 weeks to start planning what that looks like. Our social workers are a key piece of a communication between the family and between the whole care team. And we're very fortunate at DuPont to have a dedicated CP social work team for that.
And one last question on this this topic. One parent asked, what are best ways to keep records? And I think that's something that's really changing right now at this point in time. My daughter's 18, and I started out with the good old big fat 3-ring binder, you know, when she started in CP clinic as a baby. And I'm a paper person, so I keep it. Our clinic still gives me a printed out visit summary at every time we go, and it has on there printed out who I talked to, what we talked about, who was going to do what moving forward, you know, the action plan. And so I still keep those and 3-hole punch them and put them in the binder, and refer back to them. But nowadays there are lots of ways of electronic record keeping, and with hospitals moving to these coordinated systems so that one department can talk to another and somebody's chart is easy to pop up everywhere in the system. I'm sure there's all kinds of alternative ways for families to keep track of records and important information.
I still get the binder, I get the box, I get the jump drive. I'm able to see all of Nemours records at Christiana, so I do it electronically. All I ever ask for is just the time to do it right. And so keep traveling with your binder if you know that is your record. I think we sort of accept it in all ways.
You know, when I was at Phoenix Children's and we started the CP program there, one of the big things I wanted out of my nurse coordinator was that we would give them a written summary of what all their other subspecialists were doing. We were kind of taking on that role of medical home because the primary care system out there was a little bit more fragmented. And so we felt like that was providing a lot of value to our families. That's been a few years since I was out there. I think there is definitely a move towards more electronic communication with that. And I would just encourage the families to sign up for those patient portal things, because I think that electronic communication, being able to access your records without, you're then able to kind of be a little bit more portable with that. And we're able to communicate more and more, not across all healthcare systems, but more and more we're able to do that better. So I would just encourage you to do that. I think our best communication happens when a family is able to be engaged in that portal. When there's a big concern or a clarification of something they didn't quite get because maybe I went through it too fast, right, in clinic, they're able to kind of come back and clarify that. So.
Okay, well, let's move on to the topic of bone health. The first question under this topic is, why is bone health important? Why do children with complex CP experience osteoporosis and fractures?
Yeah.
Let's start out with that one.
Yeah, so I'm definitely going to qualify that. I'm the bone doctor, right? And so I definitely take care of the fractures and everything. But going back to what we said before, it's definitely a team approach. And so, the treatment of osteoporosis definitely gets more into some of the medical world. And I'll let Charmaine talk a little bit about some of that. And it's different from center to center. It's been very interesting. Sometimes I've seen the kidney doctors manage osteoporosis medicine, or the endocrinologists, the hormone doctors. At DuPont, at our institution, it's our rehab team, because it's so many kids that come to DuPont have CP and CP-like conditions that they come through our world, that our rehab team has done that and has traditionally always done that. It's very important because we know that fractures are correlated with overall health and overall activity levels in terms of participation in the community when we look at lifestyle in that way. Subsequent fractures, especially in the adult world, become such a life-altering event. And the bone mineralization problems with bone mineralization that start in kids really just kind of compounds itself by the time they get to be adults. Charmaine mentioned about the importance of cardiovascular health and fitness in adults that Ed Hurwitz and his team has been demonstrating at the University of Michigan.
Right.
Why does it happen? It's really a complex problem. By and large, it's due to the motor disability and the inability to do the typical events that stimulate bone health, running and jumping and playing, and any disability that kind of cuts some of those things or limits our kids in doing those things will potentially cause some potentials with the bone mineralization and the bone health that can lead to fractures. And then the fracture care obviously is incredibly important for us to try to get those kids back to their normal levels of activity.
I will just add, we look a lot at medication. So the quarter of my patients with cerebral palsy who have seizures and are on anti-seizure medicines, that affects the way you can uptake your calcium and vitamin D. And so medications get in the way of building your bones. So we do a ton of DEXA screenings and using bisphosphonates and talking with our teams, just as Dr. Shrader says, it's multidisciplinary. It's a endocrine and a bone health team, which has some actually sports medicine folks who help us and try to make certain that as we age, we are never behind in our screenings that we do every couple of years.
Okay.
I think the schedule for screenings for kids is something that is evolving. Typically, we probably don't screen as much for it as early on as we should. And we probably need to start, I would be very supportive of additional studies for that. A lot of times our trigger is that first fracture, but by then maybe it's too late, right? Or we're behind the 8 ball for that. I do think that we need to develop better pediatric guidelines for that screening.
I think my daughter's first bone density test was when she hit puberty. So I don't know if that ties into a developmental phase or something. A question was, should I give calcium and vitamin D supplements? And if so, how much? And what else can I do to help keep my child's bones healthy?
I'll just add that I learned from Dr. Miller, who was at Nemours and run the cerebral palsy program there, that a vitamin D level, vitamin DOH level, we really want to keep it at 35. So that is always my goal. I screen liberally for vitamin D deficiency. I try to build it with supplements. So yes, some vitamin D and calcium is a good idea, but as to how much, it would be great to have a number as a goal and work with your primary care doctor to really maximize where you should be.
You can, you can take levels enough that kind of gets into a toxic level.
Right. Right.
So you've got to be careful about that. So there needs to be that feedback, as Dr. Wright mentioned, to follow it with your primary care doctor. But we frequently in the ortho clinic will screen our kids with vitamin D and calcium levels. We'll frequently correct those levels at a baseline. We definitely look at those things, and I think as an active part of our treatment, it should be an active part of treatment in most CP clinics.
Okay. Jen, did we have any questions in the chat about care coordination or bone health?
Yeah, we have a question about bone health. My child has reached the teenage years and become a picky eater now with a milk allergy. She doesn't always want almond milk now, but does love yogurt alternative and makes parfaits for lunch and breakfast quite often. She wants to skip lunch now, and I'm concerned about her vitamin D and calcium intake. Carbs and veggies are not the issue. Please help. And I think y'all sort of answered it. Is there any, would you like to elaborate on a picky eater with allergies?
Sure. I have to say, having 1,000 units of vitamin D as a minimum is something that bodies can process. Vitamin D is one that, again, sticks around, so you don't want to have too much. Calcium, I always tell my patients, we measure out everything. If you're doing a yogurt, you can get 200 milligrams of calcium through a yogurt. But in general, the goals for a young, healthy woman, for example, are going to be 800 to 1,200 milligrams of calcium a day. So you can eat it. That's great if you can eat it. But otherwise, there are some goals that we have for the amount you should be getting in for a 24-hour period daily.
Thank you.
Yeah, I think, I think nutrition is a big part of all of our teams, both on the pediatric and the adult side. And so again, going back, we have CP specialists, nutritionist specialists that are really, that are used to working with our kids with all types of different issues, and working on trying to do a good food diary and to really follow it along, because it's hard to keep track of, right? And they come up with ways that we're able to do that, and then try to see if we can fix it by, like Dr. Wright mentioned, by food. And if we can't, then talk about other supplementation.
Okay, so we also have some other questions under the topic of nutrition. That was a nice segue there. One question was, in general, why do kids with complex CP often experience malnutrition? There's a lot of questions here about weight and kids who have a hard time gaining weight. I know that was the primary struggle with my daughter when she was about preschool age, and she finally did get a G-tube at age 3, and it made all the difference. But we really tried our best to just use nutrition to fatten her up until that point, that we just said, wave the white flag, it's time for the G-tube. So someone said, my child is always below weight on the growth chart. And is there another way to measure and follow their weight? And I know a lot of families struggle with that, because I remember the developmental wheel that you would turn, and is your child reaching their milestones? And I remember taking it and throwing it away one day, because I was like, you know what, my kid is on her own trajectory, and I'm just not even going to read this anymore, which maybe wasn't the right thing to do, but that was where I was at the moment. And so this parent was wondering, is there another way to measure and follow their weight and to see if it's becoming acceptable?
First of all, I'd just say, that description of that journey with your G-tube is so normal.
Yeah.
And you hear it over and over again for different things, for different levels of intervention and different levels of new normals that I think our families go through. And so whenever I hear a story like that, and I always try to reassure my families that I'm interacting with, that that's a normal way, that you try to do everything you can not to do that. And then, then you finally kind of agree to it. And then most of the time, it's one of the best things that's ever happened. Very glad we did it.
Yep.
I think the other thing I would say is just make sure, encourage folks to ask their providers, are they using the CP specific growth charts? Because that is different, right? You're exactly right. The trajectories are different. It's different. There are different growth charts for different GMFCS levels. And so the gross motor functional classification system levels, which is the main overarching classification that we use as clinicians and that you hear about in this meeting all the time. But I think that's really important because you'll sometimes find a very different answer. And it's important to always take the measurements related to that.
I'll just say in the adult world, we're often speaking about G-tubes as well. To swallow something requires the esophagus to have a nice coordinated, it's called peristalsis, where everything works really well to get food from the mouth to the stomach. And as you get older, sometimes that works less well. So we do a lot of swallow studies. As you get older, stuff is just, you're not swallowing well. That can happen. The whole bowel can move slower. And as you get older, there's a greater chance of that happening. So yes, sometimes G-tube discussions come up all the time, and it's not a failure. I think, that sometimes is how it's perceived, and it just simply is not. Weight also becomes a discussion as you get older, just in terms of who your caregiving team is. So sometimes there is a goal weight, not to gain weight, actually. There's a goal weight for, maintaining independence, being able to do your transfers as you get older, who's taking care of you, making sure their backs stay healthy. So there's a lot of discussions around weight. So there are slightly nuanced discussions as you age with cerebral palsy, which I'm often privy to.
And I would venture to say, I know that there's a nutritionist that meets with us every time we visit CP Clinic. And so most comprehensive teams are going to have a nutrition component to that. Also, I would say my daughter went to a special needs preschool and they had a nutritionist on staff. And when I was fighting the fight, met with her and she gave me all kinds of ideas of recipes for high calorie milkshakes and things like that to try. And as far as supplements go, I do remember there was a powder that added calories to food. And so there was a lot of things to try, but yeah, a nutritionist, if for some reason they're not seeing a nutritionist at the clinic they go to for CP care, seek one out, and they can be very helpful indeed. And you mentioned bowel function. And so one of the questions was, what can I feed my child to help with constipation? And is it safe to give stool softeners long term?
So I have very few patients who don't have a bowel regimen, at least something that works when they're in a crunch versus something that just needs to regularly be administered, for long periods of time over time. And there have been some controversial studies regarding Miralax as of late. Nothing has borne out in terms of a neurologic outcome from long-term use of Miralax. So we use a lot of Miralax. We use a lot of suppositories and Dulcolax. We really do what it takes to keep the bowel moving, to keep comfort, and to make life good. So we do a lot of bowel regimens.
And I will say too, that when we did get the G-tube and we didn't immediately go on a pump, we were doing bolus for a long time. When we finally did start her on a pump, because she still couldn't keep up calorie-wise, the constant flow of liquid, it alleviated much of my daughter's constipation issues. She had some real issues with it early on. And ever since she was on a pump for, she was very much hydrated. Okay. And hydration for her has been really the key. And it alleviated her issues, and it hasn't really been an issue ever since. So knock on wood. Okay. And couple last questions under the nutrition topic. One mom or parent said, my child has reflux and often vomits their formula. How can I reduce this? And along with that, are blended diets safe, and are there resources for those who prefer blended diets?
So I'll say reflux management is one part medicines, one part behaviors. So anybody who's getting a G-tube feed, if they also are getting any pulmonary treatments, like a vest, for example, the feed has to be separate from the vest, or anything that's putting pressure on the belly. There's a correct position for feeding, and not lying down to eat after feeding is anti-reflux management. Anyone who doesn't have a wedge or a hospital bed so they're upright, that's part of reflux management. And then you have the medications that we rely so much on, are things like the proton pump inhibitors and our H2 blockers like Pepcid, for example. So I would recommend talking with your primary care doctor and making certain you have the medical part right, but also that every one of your behaviors is also as good as you can make them. There's a lot around feeding you probably can attest to that has to do with venting, for example, and other things that can limit the outcome of reflux.
Okay, let's see. You've mentioned a couple of times already about education for physicians around adults with CP. And so our next, well, before I was going to say our next topic, but I should ask Jen, were there any questions in the chat about nutrition before we move on to the transition?
Nope, you guys covered it all. Thank you.
Okay, all right. So our next topic is transition to adult healthcare. At this point, I would ask Dr. Wright to share her screen. She has some slides prepared for us on this topic.
Very small amount of slides, but just because I actually think they are exactly what we're talking about. So it puts a picture to the words. So I'm going to just quickly just say I'm up in Wilmington, Delaware. I run a Center for Special Healthcare Needs. It's a very long name, but it's called the Center for Special Healthcare Needs because that's what families wanted us to call it. So we talk a lot about transition there. And most importantly, and you let me know, are you seeing my screen now? Do you see transition?
Yes.
Excellent, okay. So we talk a lot about what transition is, and at the age of 21, often people are told to leave their pediatrician's office and go to an adult medicine office, and we very much not want to talk about it as checkout time. Checkout time is one stop, you open the door and you leave, and actually we really want transition to be a guided process. So I am Jamaican, I have to show both, but really we don't want that baton to be dropped, right? It's a process, it's the pediatrician is coming in with everything that has happened to that child, and it needs to be handed off, and that runner needs to take off at the same speed, actually, otherwise you drop the baton. So that is really what we want transition to be like. And here's the box. So you talked about your binder. I've gotten records in all ways, and people really dread transition. People really do. They come, first time I see folks after transition, sometimes at the point of tears, because it's a whole lifetime that has happened before coming to see me. The communication that you talked about, Lynn, that's what this picture shows. So the patient's in the middle, the adult patient who's transitioning, and maybe there's still something that they're getting care for at the pediatric hospital, but they're now needing to go to an adult hospital maybe. So maybe there's an adult hospitalist who's involved, you've got the parent, you have the adult primary care doctor here, and every single one of those arrows is a vector of communication. So you have the patient and the PCP and the parents talking maybe to the school and to work. You have them speaking to home services like the pharmacy and making certain the braces and the DME are done. So this web, I show it just to say it's a full-time job to have all those conversations. So the more we can get all these folks in one place, or the more you have a team, care coordinators, social workers, we have a bunch of nurse care managers making these calls and getting the communication done, the less stressful it is for the patient and for the parent. So the youth to adult transition, we've got 10 million youth who've got a special healthcare need. We've got great news in that 90% of kids with chronic conditions survive into adulthood, but it's really risky when you change teams. It's really risky. So every year, 750,000 youth enter an adult system and they're not ready. The adult system isn't ready. There's not policies to really be ready. And then you have the patient who is a young adult who wants some say-so in their care very often, and sometimes not making the very best decisions for their care, I'll say. So there's lots of reasons why transition is risky. So there's some poor outcomes here, not surprisingly, some medical complications, lack of treatment and medication adherence, some discontinuity, higher cost of care. And so I'm just sharing this because I want you to know we're really fighting against this with these complex care programs that try to do a lot of the support of families. There's also something known as the cliff, which the lay press talks a lot about. So up until 21, there's a lot that's wrapped into the school day. PT and OT, screenings, and then you hit the age of 21 and things are no longer included in your school day and you jump off the cliff. The definition of disability is re-measured, and so you get a new adult definition of whether you have a disability or not. So it's an insurance issue, it's a healthcare team issue, it's a clinical issue. I think this puts it best for any parent who has a child with intellectual disability specifically. One day your kid is getting what she needs, you're able to go to work because she's being looked after. The day she turns 21, boom, the help ends. And so there are, again, a lot of stress around the time of transition. We're all in Delaware, Dr. Shrader and I and the Shrader family, and adult Delawareans, we actually are needing to get it right in our state, because in Delaware, there's 1 in 3 folks with a disability, and nationally it's 1 in 4. So that's why we do a lot of long-term care planning, and for everybody who's listening, that's something that I think I cannot state the importance of. As we get older, we're talking with a lot of families where the caregiver is aging and there hasn't been a lot of thought or just time to talk about what it looks like when the patient is on their own. What does it look like? So we actually had some focus groups with siblings and parents back in the fall of 2018 with a lot of other institutions who have complex care programs. And here are the things that we really have to tackle in primary care, actually, when we have an adult that's aging with cerebral palsy. From housing to legal planning, who is the primary caregiver? Financial planning, day-to-day care, medical management, transportation. So we're really trying to build a system where everybody's got a long-term care plan. If you're an adult with CP and getting older, that this is something that is shareable with siblings, shareable with family. And even as COVID has come upon us, it's become even more important to have something that is documented and shareable. So I'll just show where I work and where I'm so proud to work. And we've got lots of patients with special healthcare needs. We are extremely proud of our cerebral palsy program, where there are rehab medicine doctor who heads it, as some of the care of an adult with CP becomes less surgical, not all. We have an orthopedics that come into us from Nemours. We have an orthotist, we have wound care, we have a social worker, we have a nurse care manager, and lots of folks from bone health to radiology to nurse navigators who sort of help us put this all together. And we're really relying on our pediatric partner to do this. And you can actually see Dr. Shrader in this picture. He's right here. So we're working hard at being a place that receives someone who's aging with cerebral palsy and just keeps it seamless and without any gaps. So regionally, if you have anybody in the Mid-Atlantic area, we would love to take care of you as you get older. But I just can't say enough how important it is in transition to find a medical home, to find a team, and to have those conversations and to actually delegate and share those conversations that have to happen with a social worker and with a complex care team. So that is multidisciplinary is the name of the day, but that is what I suggest everybody really seek out, especially if you're aging with cerebral palsy. So those are my slides, and I have them more just to sort of have them as placeholders for the discussion we're already having. So thank you for watching.
Those were great. Thank you, Dr. Wright. The questions that were submitted under the transition topic, there's one question that's kind of the overriding big question, right? And that is, what will happen to my child when I can no longer care for them? That's the big million-dollar question. And all of the other transition-related questions fall under that. To varying degrees of urgency, depending on the age of the caregiver or the individual with CP. And one of the questions here was, who can I meet with to discuss my child entering adulthood? And I would say anyone who's willing to talk to you about it. The physicians typically are going to be eager to talk about that because they're wanting families to think ahead and to plan. The school teams are geared toward that. The IEP process that teachers are required to go through step by step. It's pretty structured, and they're required to start, you know, at age 14 and move your child through the planning process. And so from the parent perspective, there are people out there waiting to work with you on it. Engage and be an active participant in that planning process. And I would also say, as someone who works for Ohio Family to Family, the medical home model is something that Family Voices nationally really, really promotes and supports. And there is an F2F, a Family to Family Health Information Center in every state in the United States. And so, and a major mission of F2F is supporting the medical home model and planning and transition for disability. So here in Ohio, I'm one of 3 F2F specialists that host workshops and training events for families and professionals on transition topics. And so I would say seek out your F2F. And there are a lot of other organizations like boards of developmental disability that are having now, of course, virtual. It's even easier to find them and access them now because it doesn't matter where you are because everything is virtual now. So, you know, do an online search for transition workshops and you will find them. And I would say one that's presented within your state is one that will probably be presenting resources that you will be able to access.
Yeah, so Delaware has a state checklist that I'm holding in my hand here that you can go through. And planyourlife.org is actually a website that was originally set up for geriatrics, quite honestly. However, the categories of housing and transportation and day-to-day care and primary caregivers, it goes through all those categories. So very often I'm telling families, it's like a online website you sort of input things into, and the state specific things you have to go to your state for, but it often at least starts guiding through the process. But yes, there's these tremendous workshops. Family Voices has been huge in sort of helping train our social workers to really get it right. But I think that's a major concern. As important as me refilling your medicines is talking about this. And I think COVID has unfortunately caused us to talk about it even more. There have been cases of emergency placement, which we consider a failure on our part. If somebody is left and we don't have a plan for them and they need to be placed emergently in a spot where they might not have wanted to be because the caregiver is no longer with us. So we talk a lot about planning to succeed and planning into the future.
I love the bolt analogy about the handoff because I think it really does need to start in the pediatric side of things. And at DuPont, we are really fortunate to have a really good transition program that has another Med-peds physician like Dr. Wright with social workers and care planners. And it used to be that we would refer them like one time, you know, or maybe twice. And now we start referring patients there when they're like 14 and 15 and 16. With the plan for those are going to be yearly visits because there's so many things to talk about. All those things on that list that Charmaine mentioned about financial plan, power of attorney, things like that, healthcare planning. There's so much to think about and consider that it's hard to do that in one setting. And so I do think it needs to start when, you know, in the pediatric setting.
And so the American Academy of Pediatrics says to start at age 12, just to tell you when the process is supposed to start for every kid, actually. So, yeah.
One question that was on my list here is there a guide or a website that can direct me how to begin this process? And I would just share that one resource that I use a lot in my own transition workshops that I present is gottransition.org. that website has a lot of resources. There's checklists, you know, how ready is your child to start talking about, thinking about taking responsibility for his or her own healthcare decisions. There's some pretty detailed checklists in there. And there are some for the individual and some for the parent and some for the medical professional. So it kind of covers all the bases. So that's one resource that I would share. If you have any others.
I use gottransition.org. That's exactly what I was going to suggest.
Transitioning into the teen years can be very difficult. How can we better prepare for those transitions? And the overwhelming stressors can become difficult to get teens to open up about.
I beg pediatricians and all the residents that I teach to get the patient alone, just as practice from 15 and 16, just to direct all questions to the patient and say, you know, mom or dad or grandma can help, but I want to hear from you. I think that just is skill building from an early age. So I definitely think getting your child to speak for themselves if possible in whatever way is really helpful as practice.
And finally, on my list of transition related questions, will my teen be able to access a disability pension in adulthood, and how and when can we apply? That's a big transition topic. I know that we have a whole workshop in our series on supplemental security income, or SSI, that's available through the Social Security Administration, which is, you know, available starting at age 18 for an individual who's disabled. Do you find that that the topic comes up in your medical related conversations with families, and how does that go?
Well, when a patient is transitioning, the first questions are insurance, first of all. So a lot starts there, because sometimes we are giving the advice for Medicaid, for long-term care, for a state-based waiver system, for all the things that waivers can do. For example, in Delaware, you mentioned IEPs. And as you're an adult, if you're working, you get an IPE, an individual plan for employment. So I have patients who through the waiver are getting gas money to go to work or supports at work. So sometimes understanding what all these tools are that are provided through Medicaid is really tricky. I relearn it every month. I'm not kidding. I rely on my social workers to stay current on these things. So walking someone through their first SSI application or talking through eligibility, yes, I lean on my social workers a lot. But we have to ask the questions up front, because if I'm assuming, you know, the prescriptions for whatever DME you have, that's a day one question and a day one service I have to make certain is fulfilled, and that's insurance specific.
Yeah, it comes up a lot with us. I mean, I think that, like Charmaine mentioned, it's probably the number 2 question after insurance is about disability. And of course, it's so individualized that it's hard for us as physicians to kind of give blanket statements about that. We rely on our social workers a lot on that too. And of course, it's dependent. It's a function of the disability level for that particular individual. And so it's a hard, you know, it's just like everything with the waivers, you know, the paperwork for all of that stuff is hard. And I try to encourage the families that it's a marathon. It's not a sprint. And you've got to be tenacious about it too, because dealing with some of the government agencies, sometimes it's a bit challenging. And so just try to stick with that. But the best thing is to find a social worker to walk you through that.
Okay, Jen, do we have questions about transition to adult health care from our chat?
Yeah, first, wanted to get the perspective from Benjamin and Mason about what it was like for them to transition from pediatrics to adults. And then we have a comment or a question from Alexis after that.
Let Benjamin take it, because he's more eloquent than I am. So
well, most times, but I try. I'm sometimes hard. I think a lot of, for me, the biggest challenge was learning to take responsibility in your own care, like learning to ask the questions for yourself and learning to like things like I would have never, thought to ask, am I getting enough calcium or what have you. Like those are just not things I think about. So I think learning to sort of take the driver's seat, for like a better word, I think that was the biggest challenge for me. Does that make sense?
Mhm.
Yeah, and I mean, I would just add to that, that it is difficult. But yeah, the kind of biggest hurdle is the sudden realization that there are things that I need to kind of juggle on top of everything else, right? Because if our goal is independence, right, then ultimately that is what we have to do is juggle all of our kind of medical needs on top of our day-to-day lives. And I don't still do that great. Dr. Wright knows I'm not great at responding to like emails or messages when I need to about prescriptions and things like that. But it's the also thing to remember is that it's not like the kind of medical system so often in society at large are kind of set up to expect us to transition to adulthood immediately, and that's kind of what Dad and Dr. Wright are trying to stretch out on kind of a medical basis, some more gradual transition. And that is something that like we have to have psychologically too. Like I'm 23 and I'm still not fully like responsible where I want to be as an adult yet. Right. And so this gradual process that y'all have been talking about is absolutely important, and we need to think about it in those terms, because just personally, psychologically, that's how it works anyway. So yeah.
We have a comment from Alexis. Alexis, if you'd like to unmute, I know you prefer to speak rather than type.
Thank you. I do. The chat box is a little bit difficult. So hi, everyone. I first off just wanted to say thank you to all of the presenters. Thank you, Dr. Wright. Thank you, Dr. Shrader, for talking about transition. I have CP. I'm also 23, and I'm GMFCS level 3. And so throughout my life, I have actually never had coordinated care. I've managed most of my care by myself from a young age and whatnot, but it's hard. It's very, very difficult. And becoming an adult, so we talked a lot about the transition services, which I might be coming to see you guys. I think that might be something good to do. But we talk about planning financially and planning power of attorney type things and whatnot. I should also mention that I have multiple complex medical conditions as well. So going off of that, do you find when you're planning for the financial situations or the guardian situations that the medical issues that the patient had or has kind of go out the window as they become an adult? Because I'll give you an example. So oftentimes we find that either older or geriatric surgeons don't really have the knowledge of how to treat CP body. And even, arthritis doctors and whatnot, or GI doctors, they just don't have the knowledge of the developmental conditions. So my question is, how do you manage that, or what have you found in that area? And I hope that made sense, because that was quite a lot. But
No, I think it totally made sense. And I think, we have a huge challenge across all our medical subspecialties about how to take care of adults with childhood onset disabilities. And, as an adult, you mentioned arthritis, as an adult hip and knee surgeon, you're exactly right. They're not very well trained in how to take care of some of the medical issues that go along with a patient with CP. And even the technical aspects of doing adult hip and knee surgery on adults with CP, it's not something they do every day. Dr. Hank Chambers and I give a course on adult surgery in adults with CP, because it's hard to find folks sometimes who have that expertise and and the interest in that area. That's one of Dr. Wright's missions in the center that she's building, is to try to help work with that teamwork between us as pediatric surgeons and the adult surgeons. And we've already, in the last year and a half, we've had multiple conversations of adults that have come in that have needed orthopedic surgery, and the adult orthopedic surgeons and us talking together over the phone to come up with a better coordinated care plan. And so I think a lot of it is just recognizing that we have that issue. It's across the world, really. And then the communication to do better, because like most doctors, they want to do better. They just have never been trained and have never been taught how to do it.
So I will say, a dream of mine would be, some of these conversations have already happened. The pediatric orthopedic surgeon has the knowledge, and they actually have to teach the adult orthopedic surgeon at times when surgery is the issue. So the dream would be Dr. Shrader in the operating room with the adult orthopedic surgeon for a patient that needs surgery. And I know that will happen in the future when needed. I'll also just state, and Dr. Shrader, sometimes there is a little bit of a cultural shift of an adult with CP needing less surgery. It's less about surgery. And I think sometimes that's hard for families to hear. And I'm sometimes wading through, well, actually, we're going to medically manage, for example, the spasticity. We're going to be talking about medications or maybe a baclofen in different ways. And so sometimes surgery is necessary, but I think there is sometimes this tension in me stepping in and saying, well, sometimes surgery is less of the answer as you get older. So I'd love for Dr. Shrader to comment on that.
Yeah, I'd be happy to. I think you're totally right, Dr. Wright. And a lot of times the reason why we talk about surgery a lot in the pediatric world is because of the element of growth.
Right.
The thing about CP, our CP neurological disability doesn't change, but when you throw in the growth of the musculoskeletal system, that's why we often have to get involved. And in the adult world, by and large, that's not changing anymore. So it is not, and it shouldn't be a primary surgical solution for most things. And that's why we're not having to be quite as much of a central role in those types of clinics, because it should be more non-surgical management. A great rehab doctor like we have at Christiana is really key to really manage those things. But I do think I like the illustration about the cultural shift, because I think families do struggle with that sometimes, as it's not a quick fix anymore. Maybe it's not a quick fix really, even when we do it either, right? It's not a quick fix at all, but it's definitely not in the adult world. So.
We have,
Thank you.
sorry, thank you, Alexis. We have two more questions, but I actually think I'm going to save them for the upcoming topics. One of them is definitely related to siblings, and then the other one I think would be a fabulous one to ask at the very end. Thank you for joining us for part one of Complex Care, a Family Journey with the Shrader Family, Dr. Charmaine Wright, and moderated by Lynne Fogel. Please join us for the second part of this panel, where we'll be discussing caregiver wellness, sibling support, and education.